that probably we have not increased our bar. It is gradually coming up, but I think meetings like this will definitely increase some awareness. It can't happen overnight, but over time people would realize that this is such an important aspect of our routine clinical duties. We discussed about regional differences yesterday. I'm sure there must be a scientific way to analyze why there are this regional differences in our country in organ donation, and do some kind of multivariable analysis to find out what are the significant differences. Is it cultural, is it administrative, political, or whatever? And where do we stand here in this part of where do we stand? What are the remedial measures that can be taken? Do that and again study, see whether we are increasing or not, and see whether it increases our organ donation rate or not. I think that is the main objective of this meeting. So I would again welcome you all, welcome our international faculty, national faculty, welcome you all delegates, and we'll roll on. We have faculty from Bangalore, Dr. Sunil, a good friend of mine. He is going to start the proceedings. Thank you all for coming.
Thank you, sir. We had some very insightful full sessions yesterday on day 1, and we'll kickstart session 5. And this will be case capsules in donation after brain death. And for that, I'd like to invite upon stage our moderators, Dr. Ashish Sharma, Dr. Prakhar Gainesh, our chairpersons. I don't know if they're here yet. Dr. Mohit Kharbanda, Dr. Rajesh Singh, Dr. T. Srinivas Rao, and Dr. Dipankar Sarkar. Also, I'd like to invite our first speaker for the day, Dr. Sunil Karant, who will be talking about challenges in diagnosis and declaration of brain death.
Thank you. Yeah. Thank you to the MC, and thank you for Dr. Avnish said. Apologies, I couldn't be here yesterday due to a personal commitment. And thank you, sir, for that kind introduction. I think sir has been just too humble. I would rather look at myself as a student, and for all of you, he was my examiner as well, and luckily he passed me in the first shot. Thank you, sir. Right, so challenges in the diagnosis and declaration of brainstem death. So I think the Indian story is sort of getting better, as we know, from about 0.4 per million, it's come up to around 0.65, but a lot of catch up to do, and that's the graph, and you would probably find India somewhere out there bottom. Like we say, we are the 4th best in GDP, probably we are the 4th from the bottom in this. I think a lot of work to be done, and this is mainly in spite of the dubious distinction of us having one of the highest number of neurocritical care or head injuries as a part of everything else that's happening. So why this kind of disparity? Of course, it is a very diverse country, and as sir already mentioned about the regional differences, I think that's something which is certainly a big challenge. We do have various, diversity is a part of our life, I would say. Probably even if you look at the way medical healthcare is structured, also there's a lot of discrepancy, lots of diversity that we see as well. From the private health, public health, different types of tertiary, secondary, and the standards in each of these also vary quite a bit, and that makes it quite challenging. There are also complex ethical challenges that we talk about surrounding the very core of what diagnosis of brainstem death, and of course the following that, the consenting of the process of organ donation. So basically this is a tug of war between the scientific way of looking at how organ donation happens or how brainstem death declaration happens, and the different factors that actually contradict it, which includes traditional, cultural and regional things. Now coming to some of the dilemmas in diagnosis, I will state a few problems arbitrarily, what I thought was important problem that we have faced over the last 15 years that we have been doing brainstem declaration and organ donation, and probably highlight it with one or two cases just as an example. Largely sticking to clinical, but sometimes the line between clinical and other non-clinical issues can become a very thin line, and sometimes a non-clinical factor may be the one which will impinge the clinical decision as well. So firstly, the procedural and ethical challenges. I think as we all know, the good old THOA Act has put into place a well-structured guideline which says 4 doctors. Now that is both good and bad. I think the fact that there is 4 doctors gives objectivity, gives a certain degree of definitiveness for to say that somebody is brain dead. As you know, in many parts of the world, they have moved from having 2 tests about 6 hours apart to 2 tests following immediately, so that the time lag gets shortened, because that is one of the reasons why even families don't agree, because of the long duration of time that happens. And also, of course, the limitations of availability of some of this manpower, and also the necessary tests to be done, which is largely clinical, of course, but if you need to have an ancillary test, the availability of that is very limited in certain resource limited settings as well. And large parts of our nation are still come under the banner of middle income or low income, and so resource limitation is a big challenge. So to highlight some of this, I'll start with the first example or first case that we had a challenge with. For reasons of privacy, I've kept names, you, me, I, hit, etc. So forgive me for that. 40-year-old gentleman who was an officer in the Air Force presented to a nearby hospital, which is a command-based hospital actually, had a grade 4 SH, and he was already come with the GCS around 4-5, intubated, progressed quite rapidly to brainstem death in spite of the best of care. Coming from a army background, obviously the family volunteered, and this was about a decade ago, and just wanted to highlight what was the problem then, which probably is there still in some of the centers, but perhaps not so much in the level 3 hospitals, at least in Bangalore. So the family volunteered for organ donation, and then started the actual challenge, because the in-house hospital had not yet had enough people on board from the empanelment point of view, which has to come from the appropriate authority, as you know. And it was looking for the clinician started to become a little bit of a challenge, and the then appellate body, which was called Jiva Sarthakate, came on to actually try to help out, and they did get couple of us, myself, 1 or 2 other people from other hospitals to actually come in. And unfortunately, the neurology or the neurosurgeon also, on the day when the decision was done, was also on leave. So from the in-house hospital, so we had to actually get even a neurosurgeon and surgeon from outside. So I think the jigsaw couldn't fall together. They were able to get 2 out of 4 or 2 out of 3, and they were still, trying to get the third one was becoming a challenge. And there was already a 48-hour delay in, trying to arrange this. And so happened that twice, 2 of us had to actually go in saying that the third person is coming. We went, came back, and, it never happened till about 48 hours. Of course, the family did wait patiently, because it was their voluntary decision, and they were very keen to do this donation process, because he had in his told, I think, the wife that he would want his organs to be donated, and that is how the whole process did get started. So this was a big challenge, and after lots of discussions, eventually it was decided to shift the patient to a nearby tertiary hospital, and then the entire process started, and about 12-24 hours later this whole process completed. So that's one of the challenges. As I said, human resource, getting the necessary people on board, and if you look at smaller cities or smaller hospitals, that can become a challenge. Of course, to bypass this or to circumvent this, there is the role of NTORC, where you know how the NTORC is defined: 25 beds, 1 ICU, OT, all this becomes a part of the NTORC setup. So there are more and more NTORC or more and more hospitals which are being recognized as non-transplant organ retrieval centers, and in that way some of these problems hopefully will get circumvented, and of course most importantly provide a buffer of pool of people who are actually there to go to any part of the city or the state to ensure that these processes happen seamlessly without actually allowing the patient to actually suffer through this or the family to actually suffer through this process. The second problem, what I envisaged was inconsistencies in the brain death determination protocols. I know there is a good guideline, but the interpretation of guideline is always going to be a bit variable. So different hospitals may have different kind of ways of looking at it, particularly when we talk about the timelines, when we talk about when do we start, the 5 half-lives that we talk about of the end of the last sedation, taking into cognizance whether there is organ dysfunctions like kidney, liver, etc., which can prolong the half-life of these drugs being eliminated. There are also sort of interpretation issues on the legal, ethical parts of brainstem death itself progressing on to organ donation, and a lot of other sort of variabilities that we talk about. So this kind of also puts some barricades in the way in how we actually look at brainstem testing. So one of the examples, again, we had a patient who was a 60-year-old gentleman admitted with a left MCA infarct, presented with the right hemiplegia and aphasia, intubated. This was in an outside hospital. He got intubated for airway protection because GCS was 6 or so. And he had already reached that place from a peripheral city, from a neighboring district. And by the time he reached that hospital, it was already well past beyond the window period. They didn't have access for mechanical thrombectomy, and they then started him on antiplatelets and shifted the patient down. This was somewhere in early 2016-17 when the concept of mechanical thrombectomy had just started making inroads, and there were not many centers doing it at that point of time. And once they moved from there, in that hospital, he developed some asymmetry of the pupils, and the family wanted to come over here. And eventually, they did, of course, go through the process of having a post-operative they did have an emergency decompressive craniectomy done. And subsequently, because of the worsening GCS, which was following a hemorrhagic conversion, the patient actually developed progressed on to brainstem death. Now, here comes the challenge of, when do we call it brain death? When do we call it as an outcome becoming worse? So I think wording it becomes extremely important. And actually, at that point, the family in that hospital actually said that we would be very keen to go through an organ donation because there was somebody in the family who knew this process. He was a quasi-governmental sort of person, cousin actually of this patient, and they actually wanted to move or wanted to proceed with this process. But somehow the surgical team was not in a position to let go, to say that okay, this has reached a point of no return, and to go through the process of brainstem testing. And because they were coming from a quasi-governmental setup, the cousin of this patient, he actually approached one of the counselors, and that was when the trigger was set up. And then of course, because the family did ask, they decided to sort of go through this process. Now, this hospital was not an NTORC. They had some infrastructure in place because they were already running a renal transplant program, but for various reasons they were not having the requisite mindfulness and the willingness to go ahead, of course probably blocked by the primary team also to some extent. But I think the understanding of this concept of organ donation, brainstem death, I think was not very, very great in the institution itself as a practice, because even the renal transplant program was largely a live related program. So I think they were quite contented in that sort of scheme of things. And eventually, because the Jiva Sarthakate got involved, they had to mobilize an external team, and finally the transplant process did go through as the family volunteered. The third problem is the conflict of different mindsets within the clinician itself. For most of us who do hardcore critical care, or for many of the neurocritical care or acute neuro practitioners, I think from transiting from a caregiver to the point of becoming an organ donor maintenance clinician, or where you have switched from a person who is alive, poor outcome, to actual death, I think that becomes very hard on the clinician, understandably. And many times you are actually involved very fully in the involvement of the patient, and when the line gets crossed, sometimes it's very hard for the clinician himself to accept that this line has crossed and it is time to say that it's a point of no return. I think that is one of the sort of a dual role that we often play, and that actually also raises a lot of dilemmas in the clinician's mind, and I think that is one of the challenges as well. To highlight this, this was another patient we had, 45-year-old, who underwent a meningioma excision, a large petrous meningioma. It was a pretty large one, very close to the cavernous sort of area where the internal carotid also comes through. Patient did well post-surgery, prolonged surgery, came to ICU, ventilated, next day morning got extubated, and suddenly on third day developed a drop in the GCS, intubated and found to have massive cerebral edema. As you all know, about 1 to 2% of patients after a large meningioma excision can develop this as a complication due to various reasons. Theories have been put that it could be just the inflammatory cascade, this, that, etc. Certainly there was no sign of any infection, but this unfortunately did happen. Patient underwent an emergency decompressive craniectomy 24 hours after the second surgery. In spite of optimal care, progressed to brainstem death. Here the family was apprised about the fact that the outcome was poor, and it was almost decided to go through the process of the two tests. Somehow the neurosurgeon was not very keen, obviously understandable, because a patient who walked into the hospital underwent what would be considered as an otherwise curative surgery, ended up in this sort of state, and there was a lot of reluctance, so they wanted to wait. In fact, they were even talking about doing a tracheostomy, etc., etc. So we had to actually hold them back to say that give it some time, because it was looking quite bad anyway. So we waited for 24 hours as the as requested by the neurosurgeon, and despite about 24-48 hours of passage of time after the event where he had stopped all brainstem reflexes, there was the primary team was still not forthcoming to proceed with this process, and lots of discussion. I think most discussion was actually being held with the primary team rather than with the family. I think a lot of time was spent, and subsequently we did go through the brainstem testing process, and when we offered as a part of the mandate to say that this has happened, we could consider organ donation as a process. Is it already time up? Half an hour, no? So, yeah. Okay, so that was something which eventually ended up. They agreed, and of course we went through the process. The fourth problem what we want to highlight is the limitation of some of the ancillary tests. This is about a 30-year-old lady who again came to us by a nearby IT office. Actually, we have a large campus close by. Had a brainstem bleed and came to us with a large pontine hemorrhage. In spite of all measures, progressed unexpectedly to brainstem death clinically. However, the mother was not willing. She was living alone with the mother. She was not married yet, and so she was just not ready to accept. She was the only child of the mother who had also lost her husband. So she was just not ready to accept it, and somebody had suggested that you do a CT angio. So we did a CT angio, and unfortunately there was a small trickle of flow which was there on the left, from the left internal carotid, expectedly, because the clinical deterioration is because of the brainstem bleed. We know that, and we were expecting that we'll find some flow into the brain, and then she clung on to that and said, see, there is this thing, and obviously radiology can't report it as consistent with brainstem death as we generally say. So they just said that there is severe brain this thing and a trickle of flow there, and that is when we got stuck. We waited for another 24 hours, couple of more counseling sessions, and eventually the mother came to terms that even if this lady survives, there is nothing existing in the brainstem. She understood that point, and we were actually looking at withdrawal of life support, kind of WLST kind of a model, because we thought she's not going to proceed further. And then she said, can we consider organ donation? She's thought of the thought of her daughter living in other patients came up to our mind, and eventually I think we went through the two sets of brainstem tests again, because the old one was about 3 days back. We didn't do another imaging, and we declared the patient clinically. Problem number 5 is the safety of apnea test. Here again, willingness of the patient is very important. Sometimes they say, why are you doing this? You're putting my patient into risk. Now this was a high velocity RTA of a front seat passenger, young man, bad head injury, severe chest trauma, was airlifted to our hospital, lots of lung contusions, facial fractures, and the contusion evolved over 48-72 hours to severe ARDS, ended up needing to be prone. So we did an ICP because we had no control on the morning of the patient GS, so we had to be on deep paralysis. So it's initially wasn't done, but by about 4 days started opening up, and he did cause severe brainstem death. However, because of the bad ARDS, it was not possible to subject him to any sort of apnea test. So we did prone him, gave time for the lung to get better. In fact, it was a little more than 24 hours that we kept him proned. Luckily, he was an early responder. He responded well. We supined him, gave about 48 hours for the effect of all the sedation to wash off, and then we actually went ahead and did the clinical testing, which he tolerated well, and eventually the patient went through for brainstem organ donation. The next is about the role of ancillary test in the Indian context. I think this is something, as you know, it's not well defined in the THOA Act. However, based on a case-to-case basis, the appellate committee has the right, or some of the experts in the state have the right to take a call. We know that when something says that there is no flow, it does indicate that there is a sort of brain death, or sort of, there is brainstem death. However, because of the non-clarity in the law, I think there is a little bit of a legal dilemma. Many times you talk to the legal experts, they do say that this cannot be the only source in how you declare people. Again, we had a similar example of ACOM aneurysm for a 50-year-old gentleman who did have a ruptured aneurysm. Here he was, he progressed quite rapidly, and the family just refused to accept the fact that this thing. So here was one place we did take the help of the ancillary testing. We did a CT angio, demonstrated there was no intracranial flow, and eventually the family came to terms because there was objective evidence to say that they didn't have any flow in the blood flow into the brain. And lastly, I think the most important problem for us when we talk about clinical brainstem testing is fulfilling the requisites of the four or five requisites, because that's the first phase of the brainstem testing. As you know, no hypothermia, no metabolic changes. Sometimes that becomes a real big challenge to do. Of course, other concerns also do have a bearing in the Indian context. Family-centered decision-making, sometimes large extended families living in different parts of the world. They also need to be stakeholders, cultural and religious perspectives, challenges in communication, and of course, when do we do the donation? So just thought of highlighting our journey as well in Manipal, Old Airport Road, Bangalore. We started, the first donation actually happened in 2003. Last slides are done. Yeah. The last slide, done. 2003, and from then onwards, 10 to 15, we have done about 200 brainstem declarations and about 95. Last 2 years, we have had about 60 to 70% conversion, and that's what we have been doing. So thank you very much. I've skipped that last part of it here. Yeah. Do we have any neuro physicians or 10 years are there.
I think the major, major challenge what we face today is identification and referral. So I just want to understand what is there with the neuro people. They know that this patient is dead, but they still have reluctance to refer the patient for the donation pathway. So what is this reluctance due to, and can we overcome it?
I'm working with the critical care specialist here. So I think the surgical team, once they operate, then they are reluctant to go ahead with that brain death and this thing. So that's what the slide put is hitting very close to home. That's what is happening in my ICU. I was wondering if the first step of doing ahead with this will be to confirm with the surgical team that the patient is brain dead. That because the surgeons are very reluctant to accept that the patient has gone. So what in our ICU, what we do is we use transcranial Doppler, and if the transcranial Doppler is showing reversal of flow, the surgeons are at least convinced that the patient is now brain dead, and then we can proceed with this.
Yeah, so I think the challenge, to give due credit, I think they are much amenable these days. Last 5 years, our challenge is much lesser, but early part, as he said, when we took over the neurocritical care, it was a real challenge. And more so, I think, when it happens in the context of an elective surgery. Now, they are probably more okay to accept it if it is in the context of a post-trauma or something. But when you talk about an elective surgery going haywire, I think that is when they are a little more difficult for them to accept.
Yeah, like the case which you have shown.
Wait after surgery for
nothing. I don't think there's any
The case which you have shown, meningioma, there the acceptance will be very less.
That is exactly the point. Yeah.
That's like the family and the surgeon's relation is also important out there.
Yes.
He will be buying some time to actually imbibe that this is happening and all. That's his context.
I mean, it's not only
Our
the,
context-
it's not only the post-operative cases, right? Even in the trauma were broad.
Trauma, I think the
Well,
acceptance
it's a bit
is slightly
easier
better,
actually,
sir. Like
because-
what we see regularly in our ICUs and all. And here,
Trauma, infarct, they are a little more, if there is an external agent which has caused the problem, they are a little more easier to convince.
No, the thing
Of
is,
course, I didn't have time, but we of course did speak to the surgeon. That's why the reason we didn't go through the test in the first 24, 48 hours. And at some point he was they were sitting on the fence. We
Some-
thought,
Yesterday we discussed how all these things had to be taken away from the purview of the surgeon and the neurologist.
That's-
To be data. So we discussed how to do it. We understand that the neurosurgeon is operated, that we should hold back on talking to the family, but the data has to come that we have a potential donor. And then collectively everyone decides that not today, tomorrow 9 o'clock we'll engage with that. But we can't let it go under the radar.
Absolutely.
And let's hear from Philip what happens in US.
Who is paying for the treatment in your patients?
patient.
It is self-pay. I think that may be an issue. Because in the US it's very clear. The hospital is accepting insurance, government insurance, which is Medicare dollars, which is against the law. They cannot refuse to let you know that brain death has occurred. They cannot refuse to allow the ICU intensivists to test for brain death. They are completely out of the picture once the GCS has completed.
So I think that is what we need to follow, that we need to eliminate their role for the referral. So referral has to be primarily by the intensivist, not by the neuro. They need to be out of this
But I
consenting
think,
process.
It also depends on the
think,
model of the ICU. If it is an intensive care driven, intensivist-led ICU or a closed or a semi-closed, then
no,
maybe it's easier.
that's fine, but here in India, the thing is a little different. Patient is self-paid, so it's no point insurance or something coming up. Now, the second part, which is quite tricky in this situation, is that the patient came walking, right?
True.
You have operated. It's very difficult to make the party understand, and there is a legality to it.
Yes.
If they think that they will sue the surgeon, which you can prove that 1% can happen, but that puts the patient in dilemma of doing
So
anything.
I think, here I like to interrupt here. Even if the patient has come walking, he's still dead, right?
Yeah.
You can't make him, so not allowing organ
What is the
donation.
status? I don't know what is the status of the legality if the patient relative wants to go to the court.
Suing will happen if the patient is dead, irrespective of it.
Yeah.
You have to declare at some point.
Yeah, so that's it, but
It
can't be
held back, no? The fact of death can't be held back.
held back, but whether you can procure the organ or you can go on doing the things, or whether it will be part
No,
of
no,
the
I think-
insult to the injury.
So I think we probably need to engage more with the neurosurgeons and neurophysicians and intensive. Dr. Philip, please.
Ethically, we are going to increase the billing also. We are not declaring.
Absolutely.
No, that I think that generally gets stopped. So actually in this case also, after it was known, even the surgeon said we spoke to management, we stopped the billing. All that we have done.
No, even without organ
But
donation also.
that is a point definitely. Like why run the meter unnecessarily?
So
But
Dr.
yes.
Philip, please.
We have to accept one thing. Organ donation is the highest triumph of good communication. If you get an organ donation, chances are this patient will never sue you. The chances are more of getting sued if organ donation has not happened, because the communication is totally broken down. That is a hallmark of broken down communication.
No, that's the problem with the surgeon who has operated. They are quite apprehensive of that.
Transplant coordinators can probably.
So I think we probably need to engage more with the surgeons. I think that's one area where the society has to work further.
For this postmortem thing, so we recently had a patient found unconscious at home, and it was a medical legal case. So the family, even though they are willing, we had to send the patient to postmortem. Yes. Now this, after this postmortem, then getting the, and when they do the postmortem, they will take the samples from the organs and everything. So from getting that thing, the postmortem done fast, and then going for the organ donation is an issue here in India. So if there's a medical legal case, the patient going for a postmortem examination, even though it's not for suing purposes, for any other purpose, if the patient is going for a postmortem here, then the organs, the time period for taking the organ is very difficult to attain here.
Yeah, in India, Dr. Phillips, the acceptance levels are in a bit different way. Like recently we had one patient where they signed for all the donation, they accepted the primary relatives. After that, like they came in and said, we are okay with liver, but not kidney. We have some doubts on that.
Happen,
Such kind of things goes on like that.
Universal it is happening. Yeah.
Everywhere in the world is the same story.
Yeah, that is.
Nothing unusual. In fact, acceptance of request, consent in India is the highest in the world. Wherever it has been done in a scientific manner, which means that you have to debrief it, you have to get better and better with every consent, in every interaction. A point will be reached, and I think the gestation period is not more than 1 year. Your coordinators, and we call them family service coordinators in US, so that they don't get that transplant. Family service coordinators success rate in India when it is done with little experience. And one of the big problems I'll tell you in America is the nurse looking after the patient from the neurosurgery side is not an experienced one always. They do not establish that empathy. They are all the time fiddling, this test, that test, this, that. So the patient's family gets an idea that, there's a lot of activity happening here. Whereas a mature nurse will say that, we have to calm down and let the family service coordinator talk. Then
I think we,
so good, they'll help you.
Thank you, Dr. Sunil, for a wonderful presentation. So may I request now Dr. Tanmay to come over and he will share his experience from Kolkata. Dr. Tanmay, please.
Good morning, everyone. So this is just to continue on what Dr. Sunil was talking on. Basically, I'll just share two cases we have done recently back-to-back in September, and that will highlight some of the issues that he was discussing and we are discussing in the first session. Can you have the PPTs, please? So Dr. Avnish asked me to just keep it short, two cases for 7-8 minutes presentation and then discussion, 50% time for discussion. So this is the time when we had our name C license changed from Medica to Manipal, EM bypass. And that the same month that we had two patients who actually family consented to donate and was brain dead. So first patient, she's a retired government doctor. She was a former DHS actually, 76-year-old female, admitted on 10th late night, known diabetic and hypertensive, and she presented with right-sided weakness and slurring of speech on 10th of September. And she had one episode of GTCS, following which her GCS had fallen. So on examination, sorry. Yes, so at presentation in the emergency, her GCS was E3 V2 M4, vitals were stable, and she had left lateral gas palsy with bilateral pupils pinpoint reacting sluggishly to light. But subsequently what happened when she was transferred to ICU, her GCS dropped further to E1 V1 M2 and she had to be intubated, and neurosurgeons advised to give mannitol, 3% NaCl and also levetiracetam, and she was given actrapid for high blood sugar. So this is the first CT scan on the left side which showed a left gangliothalamic bleed, and there's a second CT scan following intubation which showed further deterioration and more bleeding. So here obviously clinically and radiologically we have a patient who is a potential brain, maybe progressing to brainstem death. GCS was 4 at that time. This is chest X-ray, blood reports initially were all fine. There was some mild AKI due to mannitol, but then it improved. So she was managed conservatively during that time. She was still not brainstem dead, but while waiting, she had an episode of bradycardia and hypotension and had a cardiac arrest, needing 2 cycles of CPR, then had a first AF for low potassium, was treated with potassium chloride and amiodarone. Further, the day 4, she was found to have a GCS of E1 VTM1, and all the brainstem reflexes were absent, and we had planned for apnea test. But what happened, due to change of our C license, we couldn't do an apnea test on that day because our brain death committee was in the previous hospital's name, and we had to change that. So we discussed with the family. Family were mostly sort of willing, except one daughter who was living in Canada who was due to come, but they were counseled, they were talked about, and we said that we'll wait till we get the approval of the committee. And I'm happy to share that the next day morning, we sent a first application for renewal of the old committee in the new name, and we got it approved on the same day by 5 p.m. And that was really, really helpful. Otherwise, I think we couldn't have progressed to donation. And following that, we did the first apnea test, which was positive on the same day that we got the approval. 5 p.m. we got the approval, we did at 5:04 p.m. We're ready. Whenever they call and tell us that you go and do it, we just did it. Then we did it, the second apnea test at 11:40 p.m. Both were positive. And in the meantime, she was put on organ maintenance protocol. But problem happened is that verbal consent of organ donation was obtained from the family, but they were still reluctant to give written consent before the daughter from Canada arrives. She just wanted to see her mother one last time. So ultimately she arrived on the same night, late night, and then 3 organs and 1 tissue was donated. Liver went to IPGMR, both kidneys en bloc went to RN Tagore. Because patient was diabetic and a bit elderly, they wanted to take both kidneys for one patient. And then the cornea went to Sankar Netralaya. So challenges faced, actually obviously as I said, stabilization after cardiac arrest, sensitivity in counseling, elder daughter living in Canada, delay in that, and also approval for the new or renewal of the new committee within 1 day. But maintaining organ vitality during that period was a sort of challenge as well. Ultimately, I'm very happy to share that it happened, and and we could manage everything, all the legalities within 1 day.
So at what stage did we start the donor maintenance protocol?
We did, when we saw that there was no brainstem reflexes. We couldn't do the apnea test because obviously brain death committee, there was a 1 day delay, 24-hour delay in that. But we did start organ maintenance protocols since we saw that there was no brainstem reflexes. Because we knew that apnea test would be positive anyway.
The earlier we start, the better. That's wonderful.
Yes. An apnea test.
She got position because she was working in the same office, right?
Yes, she was a DHS, Deputy Director of Health Services, former. So retired, and the Sastha Bhavan was very sort of sensitive and very sort of helpful because of that. So my second case that happened around the same time. So within 24 to 48 hours we had 2 donations. So this is another sort of dilemma I'll just put in front of you. He was a 65-year-old man with no known comorbidities who presented with 1 episode of Hall at home and then hematemesis. And we thought that probably he had vomited blood, became hypotensive, postural hypotension, and he had a fall. So at presentation, his GCS was E1 VTM2 after intubation. Pre-intubation GCS was around 6. He was hemodynamically unstable because of the GI bleed. And in the emergency department, he was resuscitated as per the protocol and put on ventilation, and all investigations sent. Further course in ICU, because of the hematemesis, he was referred to the GI team and transfused blood, 2 units of PRBC, LFTs and baseline kidney functions were normal. He had an upper GI endoscopy on the same day, which showed a Fordyce class 2A duodenal ulcer, for which hemoclip application was done. ABG showed high anaemic metabolic acidosis with some developing AKI. Day 2, we did a NCCT brain in the morning, looking at the GCS. We stopped atracuronium, fentanyl infusions and everything, but there was no improvement in the GCS. It still remained E1, VT and M1. So he was referred to neurology and neurosurgery. This was the photo from the upper GI endoscopy, and this was his CT scan. So basically he had a traumatic brain injury due to the fall at home. So simultaneously both things happened together. So we had to manage the GI bleed, stabilize hemodynamically, and then we can only think about proceeding for testing the brain and sort of proceeding further. So day 2, steroid NORAD, nephrologist advice was SLED because of the acidosis. He was transfused PRBC. Post-dialysis, he started actually improving. The acidosis improved. Fortunately, urine output started improving and creatinine also, which went up from baseline to around 2.1, started to come down to 1.5 by the following day, in the day 3 and day 4. But however, there was no improvement in patient's clinical parameters. Brainstem reflexes were absent, as we found out. Patient was planned for first apnea test, which came out to be positive. And obviously, opinions from neurosurgeons, neurosurgery, neuromedicine department was taken. But problem happened there. We couldn't do the second apnea test and declare brain dead because it was an MLC case. Patient had a fall at home. Someone was mentioning about this just beforehand. So what happened? We approached the police asking for clearance to proceed for second apnea test and declare brain death. But they said, no, he needs a postmortem. You cannot do organ donation. Then after that, we would not be able to do postmortem. So actually, I spoke to Dr. Avnish at that point of time. He sort of said, no, this can be done. We approached the people who does the autopsy, the New Medical College Forensic Department, HOD of NRS MCH FS department. And he sort of kindly sort of said, okay, I'll talk to the police. You can go ahead with the organ donation after second apnea test if it is positive. We'll do the autopsy in your hospital same day after the organ donation. And then we sent a letter which was approved by the HOD, FSM department, and then this was sent to police. Police then gave the clearance, then we went ahead with the second apnea test. And fortunately, second